Good morning and welcome to From Siloed Budgeting to Financial Integration, where does the EU stand in diabetes care? My name's Laura Shields. I'm the Managing Director of Red Thread Communications and I will be your moderator for the next hour and a half. Just a little bit of context. This is the fourth event that EFPIA has organised discussing the topic specifically about diabetes. But today we're going to narrow the focus even more and look specifically at financing and integrated healthcare systems. And today also sees the launch of a report authored by the Economist Intelligence Unit, which looks at how to implement integrated diabetes systems in Europe. The EIU, Economist Intelligence Unit, has also produced a scorecard where you can see how well member states are doing when it comes to taking an integrated approach to diabetes healthcare. And you can find both the report and the scorecard in the chat where we'll be posting them very shortly. So you will have them there to look, and I can see it's the scorecard is up there now. So do have a look at that if you would like to. So today's webinar is going to bring across different voices from health economists, from politics, from the industry, and the sort of diabetes sector in general to discuss how to move away from silo budgeting and towards improved financial integration in diabetes care. In a moment, we'll unpick the report's key findings, and after that, our panel of experts will explore the issues in more depth and look at ways in which we can move to having more integrated diabetes healthcare systems across Europe, and also what role the EU can play, given that health is obviously a national competence. So a couple of points about housekeeping first. As mentioned, you can find the report and the scorecard in the chat. They've been posted there now. You will be able to post questions throughout the event as they occur to you. So please do it via the Q&A button rather than in the chat, because that's where we'll be selecting them from. And please, if you are going to ask a question, a plea for me as the moderator, keep your questions short, focused, and try and avoid three-letter acronyms where possible. You have a much better chance of getting your question asked if it's specific, it goes to someone in particular, and most importantly, we can all understand it very clearly. So please keep it short and sweet. We'll also be running some polling throughout the panel or in the top part of the session. So when the time comes, please do submit your answers through the polling, and we'll keep them short and snappy as well, so that it's just an instant engagement, and we'll be using that for the discussion too. So before we get into the findings of the report, we are going to have a bit more of a video to frame that. But first, just a reminder, the event is being recorded. You will be able to watch it back later on YouTube and also on the EFPIA website. And finally, if you want to keep the conversation going on social media, please use the hashtag #QuestionsInspireSolutions. So that's quite enough about the housekeeping. We're now going to get straight into the meat of today's session. But to do that, let's have a quick look at this short video to set the broader context for today's discussion. And we are joined now, I'm very pleased to welcome Dr. Prabhav Trivedi, who is from the EFPIA Diabetes platform, and also Ellie Vaughan from the Economist Intelligence Unit, who is one of the report's authors. So Prabhav, thanks very much for being with us today. Just to get straight to the point, can you tell us about the objectives of the report? Why did you decide, or why did the diabetes platform decide to focus on the implementation of integrated systems? What do we mean by that? And why did you think it was important to do it now?
Yeah, thank you, Laura. And I must say, every time I see this video, I feel inspired. So within EFPIA Diabetes Platform, EFPIA members have come together to be an active partner in the fight against diabetes and trying to improve the lives of everyone affected by the disease. And we are led by three interconnected objectives. One, raise the recognition of value of innovation in diabetes. Two, improve health outcomes in people with diabetes. And three, work towards sustainable financing of diabetes care for the future, which brings me back to your question, why this initiative? So what we know is that for complex disease like diabetes, we need rather urgently sharp solutions and policy directions at macro level to be supplemented by robust national and local implementation if we were to contain the impact of this disease, including health, social, and economical impact. And it is widely recognized that integrated care model is the right solution for the problem. It does lead to better outcomes in people with diabetes, but also leads to financial efficiencies. However, widespread implementation of integrated care model remains a distant goal. And that is the thought process behind this initiative, Laura, to investigate broad level policy directions for integrated care. And later we will see that this seems to be the case. But more importantly, enablers and barriers we are trying to investigate through this research. I must highlight that when we started this initiative, it was way before COVID really hit Europe. But what COVID has done, if at all, is to reinforce the fact that diabetes, people with diabetes are not only prone to direct consequence of the disease itself, but also prone to suffer more if they develop other conditions like COVID in terms of morbidity and mortality. So I think that's the background why the initiative and why I think it is very, very high time that we do this now and further channelize it to the right platforms.
Thank you, Prabhav. Ellie, obviously we've been talking quite a bit already about what we integrated systems, and they were mentioned in the introductory video as well. Can you explain in a bit more detail to the audience what we actually mean by integration when we talk about integrated diabetes systems?
Yes, certainly, Laura. So Prabhav mentioned there about integrated care, and that's a very specific part of integration, and that's the integration of clinical services primarily. And the reason why we opted for the phrase integrated diabetes systems was that we wanted to find a concept and a sort of a phrase that brought together all aspects of diabetes services. So again, as we just heard, it's a complex condition that requires a lot of different inputs. So we wanted something that covered diagnosis, treatment, care, health promotion, all of these different aspects. And the way that we've sort of interpreted integrated diabetes systems are that they comprise both horizontal and vertical integration. So horizontal integration being different services at the same level working together. So for example, endocrinologists working with eye care specialists, with cardiovascular specialists, etc. And then also vertical integration, where healthcare providers and professionals at different levels work together. So that's primary care physicians, perhaps working with endocrinologists and other specialists. Because we felt that, as Prabhav mentioned, integrated systems really offers an opportunity to reduce the fragmentation of care within diabetes, to increase the efficiency, but also the effectiveness of diabetes services to the benefit of both people living with diabetes and also the health systems that are supporting them. And as we've already mentioned, integrated care has been quite widely sort of adopted, and also especially it's been extensively discussed, and the barriers and enablers of it have been explored. Whereas what we were interested in was really looking at the enablers of these integrated systems. And that's why we focused in on integrated IT and finance systems, because we early on identified in the literature review that these have been less well studied. So these were areas that were ripe for further investigation.
Thank you, Ellie. And so obviously that's the concept and the approach of the report explained. Can you tell us a little bit more about the key findings of the report and also the central piece, the scorecard for the different countries across Europe?
Certainly. So the Integrated Diabetes System Scorecard measures the level of integration in 28 European countries. So that's the 27 member states and also the UK. And the purpose of doing this was to enable us to compare across different countries. And this enables you to see where there are areas for development in particular countries, but it also identifies countries that potentially others can learn from. They can share experiences, lessons learned, etc. And the scorecard was structured around two domains, which were the impact of diabetes and the presence of enabling elements for vertical integration. And the indicators within those are essentially questions which we then score countries based on those answers to them. And overall, in terms of the findings, all 28 countries scored well in terms of the integrated services that were in place, so essentially the integrated care mechanisms, with 22 of them actually achieving a full score in that domain. And then when we came to looking at IT and finances, it was a lot more sort of patchy in terms of how different countries performed. And in terms of the finances in particular, we found that only 7 countries scored fully within those indicators, and 8 of them didn't score at all within the 2 indicators within that subdomain. And similarly in IT, we found that there was generally sort of fairly good coverage of electronic health records, but the interoperability of them was a little bit more variable. And then finally, we found that there was quite a big gap in terms of the registries, the diabetes registries, and their availability in the countries that we looked at. So those are the sort of headline findings.
Thank you. And obviously, as mentioned, you can, for the audience, you can, of course, read in more detail because you have the report link in the chat. Prabhav, so based on, Ellie's obviously talked about the key findings. From your perspective, what were the key policy recommendations that emerged from the report?
So the report provided 3 policy recommendations. First piece, I think, for me is absolutely critical, is for healthcare ecosystem to organize itself around the needs of people with diabetes, needs as expressed by people themselves and as required by their clinical condition. And this applies not only at micro level, where preference or need of people with diabetes should form part of the goal setting when there is a dialogue going on between a provider, healthcare provider, and an individual. But these should also, the needs should also be applied at macro level, where their voices and their preferences should be heard and reflected in larger policy level decisions. The second recommendation, which is also a major finding of this report, is for budgets for diabetes to be vertically integrated. This will allow commissioning of services along the entire care pathway and will support interprofessional teamwork and reduce hopefully fragmentation. And I will just spend a few more seconds to explain what I mean by this. So in simple terms, a person when diagnosed with diabetes is likely to have or follow certain pathway and have interfaces with many specialties, but also other healthcare professionals, payers, educators, self-management support, etc. And in current system, which is relatively fragmented, these services are provided, but independent of each other. So if there is an intervention, which if applied in primary care, reduces the risk of hospitalization, which is a part of the hospital care or that part of the budget, you won't necessarily see the benefit of applying that intervention in primary care because there it reflects as a cost and there are no apparent benefit within the primary care. So I think the fragmented system does not necessarily work, and the recommendation is for budgets to be vertically integrated and pooled. And the third recommendation is to ensure robust evaluation and monitoring mechanism through a set of metrics. Now, this is not necessarily a new recommendation, but absolutely fundamental, and it cannot be stressed enough. It is important to include key stakeholders, importantly, people with diabetes, when we are selecting outcome measures to understand the true meaning of value to a patient and wider health system. So if you include patients, you're likely to come up with metrics, which are, for example, rates of diabetes complication, patient preferences, out-of-pocket costs, etc. So all these things have to be built into eventually what we can call as a robust evaluation and monitoring mechanism. So these are the three recommendations, Laura.
Thank you very much, Prabhav. And Prabhav and Ellie are going to stay with us because we're actually going to be discussing in a bit more detail in a moment. But first of all, we're going to test the audience's knowledge with our polls. So we're going to ask you 3 short polling questions now, and you'll be very pleased to hear that the answers are not long and complicated. There's a right or a wrong, and it usually all involves numbers. So if we could see our first poll up on the screen, please. Question 1. How many European countries, so EU 27 plus the UK, have implemented a policy to facilitate interoperability of electronic health records? Is it 9, 17, or 24? Oh, people are very quick off the mark here. This is great. I hope it's not just Ellie and Prabhav. Okay, so the polling is now closed and the results. So what did the audience think? Well, the audience, the majority went, 71% went for 9, 24% went for 17, and 5% went for 24. So people, the majority or a third of the audience thinks that it was 9, and that is actually the right answer. So well done, audience. It's good to see that you're on the ball this morning. That's great. So Ellie, follow-up question for you. In the 9 countries that have implemented a policy to facilitate this interoperability of health records, can you give us concrete examples of where this has been beneficial to patients and how?
Yeah, so I think the benefit of interoperable electronic health records really comes in 2 ways for people with diabetes. So I think the first benefit is that interoperability facilitates exactly the kind of communication, information sharing, and collaboration between healthcare providers that integrated systems are working towards. So it's really a central enabler of that integrated working. And it helps to reduce the service fragmentation that Prabhav mentioned earlier, but it also does things like it reduces the burden on the person with diabetes to remember all of the information that all of the different healthcare providers they're speaking to have told them. So if there's a centralized mechanism where all of those different providers can see all of that information, the burden is no longer on the individual. And I think also it's good because it encourages healthcare professionals to have a more holistic view of the person that they're treating, rather than just focusing in on the particular clinical parameters that are of interest to them. And this is really important because it enables that more sort of person-centered care, exactly as Prabhav mentioned earlier, thinking about how we center care around the individual rather than sort of making the individual fit within the existing systems and services that are in place. And then the second benefit to sort of interoperable electronic health records really comes when systems are set up to enable citizens to interact with their own electronic health records. And I think this is really important, especially in diabetes, because it enables people to take greater control of their health, and it also gives them access to the same information that their healthcare professionals are using to make decisions about their care. We talk a lot about things like shared decision making, and actually giving people the data and information to support that and support their input into that shared decision making is really important in a step in empowering people with diabetes. Because fundamentally, people with diabetes have to make micro decisions throughout the day, every day, that influence their health, what to eat, how much insulin to take, when to take it, etc. And so it's really important that they feel part of those bigger decision-making processes as well. But as I say, that can only take place if they have access to data to inform that decision-making. And it's also important because, as the video showed earlier, diabetes is a chronic condition, and some people describe it as relentless as well. And so it's important that people feel empowered and in control of their own health as much as possible, because people with diabetes have to learn to live with it, and importantly have to try to learn to live well with it as well, because it's something that they will have to deal with for their whole life. And I think in the poll we highlighted that 9 countries had an interoperability policy, and I don't know whether I should be reassured or depressed that people guessed that correctly. But we also had 12 countries that had a sort of interoperability that was covered in broader e-health policy. So the situation isn't quite as dire as it might have at first seemed, but that still means that 7 countries that we looked at didn't really cover interoperability in policy in any sort of really tangible way. And the importance of this is that without that kind of interoperability, exactly as I mentioned earlier, it seriously undermines the ability of different health providers to work in an integrated way, because they need to be able to see what other people within that integrated pathway are doing in order to provide that care that is really centered around the person as a whole, and not just the cardiovascular system, not just the eyes, etc. And that's something that overwhelmingly healthcare professionals do want to do. And I think finally, I just note as well around the COVID-19 context, as Prabhat mentioned earlier, this report and scorecard was commissioned before COVID-19 hit. But I think that it's really highlighted the importance of information being available digitally for starters. And also it's highlighted that this information needs to be available to all of the healthcare professionals involved in providing care. We've seen a lot of services moving online, and it's really just highlighted that this is no longer something that is a nice to have or a luxury, etc. It's really something that needs to be part of the fundamental architecture of all health systems. Thank you.
Laura, if I may just add a short point here,
Please do.
a real perspective from a person with diabetes that once diagnosed, and it's a chronic illness, goes on for many years. So imagine if a person from the first consultation to the 100th consultation, every time they have to go to a clinician, different clinicians or other healthcare providers, and still explain their situation from the grassroots. So I think it's absolutely critical that health records are interoperable. They talk to each other, of course, with all due consents that needs to be taken for that to happen. But even from patient perspective, this it's something like flying an international flight. Everything is taken care of, basically.
Thank you very much. Okay, so let's go to our second polling question now, if we may. So, how many European countries have incentives for providers to facilitate integrated care in diabetes? Is it 6, is it 12, or is it 20? And the polling is closed, and if we can see the results, so 63% think it's 6, 23% of you think it's 12, and 13% of you think it's 20. So actually, those of you who said it was 12, you're the ones who got it right. So well done on that. Those of you who said it was 12 have got it right. So well done on that. So in terms of what the follow-up question I have for you there, Prabhat, is, can you explain what the link is between incentives, further financial integration, and positive patient outcomes? And what type of incentives have been proven to have the highest positive impact on patient outcomes?
So, in literature, financial incentives for obvious reasons, have been identified as significant behavioral influencers. And if we have appropriately built incentives into the payment mechanisms, these have shown to encourage multiple providers to work together and ultimately enable better care. Of course, these mechanisms themselves are likely to be very, very complex. So in the report, half of the 28 countries incentivize care providers or clinicians to deliver integrated care. Now, these incentives can be financial or otherwise, such as changes in the reimbursement model to acknowledge the time the providers have to devote to achieving integrated care activity. And these could be simple things as attending those trainings or meetings, which are vital to care for coming together to be integrated. In terms of what works well, I think there are two challenges for a very clear answer. One is we do not have a robust data. Definitely not with a head-to-head comparison in terms of which model works better than the other, which makes interpretation challenging. But also the other challenge, which is important, is the local context differs from country to country. So it is unlikely that one size will fit all, or one model will emerge superior to the other across the European countries, for example. The report does identify three, excuse me, does identify several examples now, and I'll highlight three of those. One is from Portugal, where they established a system of local health unit which promotes coordination and collaboration across various levels of care within a defined geographic area. And then these have been financed through a mixed model, which includes adjusted capitation, payment for performance, and all these are built in to the service level agreements. And the number of projects within and outside of local health unit system have been implemented through this project. And to cut the long story short, ultimately there were mixed results from the entire exercise, but there were some very good signals. For example, decrease in the number of hospital readmissions, especially in those living with diabetic complications, and this reduction was as much as 30%. The other example comes from Netherlands, where they implemented a system called bundled payment, which involves different elements of care for chronic disease like diabetes to be purchased, delivered, and billed as a single product or services. And all the services in the bundles are fully covered, so there are no out-of-pocket expenditures. So the project implementation led to providers reporting significant improvement in perceived quality and patient-centeredness, and the use of hospital-based specialized care declined by almost 20%. And the last example comes from France, where the project, previously with a different name, but then came to be called as Payment for Public Health Objective, PPHO project. And the idea was to improve quality of care and encourage efficient practices like integrated practices. Importantly, though, this project was built on top of current system. So the existing fee-for-service system was still kept, and then they added a set of indicators, 29 of those, which depended on process, structure, and importantly on outcome. So through the project, in one financial year, average GPs they stand to gain almost 5,000 euros when they perform better on these 29 indicators. And when they perform better, we can imagine there was more collaboration in terms of care for diabetes patients. So I think these are just some of the examples. There are more examples through the literature also in the report. I just want to highlight the binding principle of pooling budget to make them more patient-centric remains across this different model. And then depending on local context, different versions can be implemented. Some points noteworthy are that these have to be, and this has to be an incremental shift from current model to the new model of integration or pooled budget, because it is a change and it takes time for change to be accepted. It has to be supported by sustained efforts, not short-term, but long-term efforts, and also financial security, because upfront investment could be higher for us to achieve long-term gain. So all these have to be backed up by willingness and determination also from the various governance structure and also at high level in the political system. Final comment on this one, for as I had said before, that the budget or the incentive mechanisms are likely to be complex because they have to depend on many indicators, and therefore to have a robust information technology mechanism which allow us to measure this indicator is also absolutely vital. So these are my comments, Lara.
Thank you very much, Pallav. And if we could go to our third polling question now, please. Okay, so what proportion of European countries have evidence-based care guidelines on multimorbidity management, including of diabetes? Is it 40%, 60%, or 100%? Oh, ye of little faith, the answer is actually 100%. So for those of you who, the 9% of you who went for that, this is what you can see. So 40% of you, 44% of you thought it was 40%, 47%, so almost half of you thought it was 60%, but actually the 9% of you who said it was 100% were absolutely right on this. So Prabhav, this is probably the most positive point that's been brought out by the scorecard. And the use of shared guidelines and protocols across disease fields and healthcare specialties allows diagnosis and treatment to be standardized across different providers and institutions. However, as we can see, there are areas for improvement, as not all countries have established national diabetes care guidelines, incorporating both vertical and horizontal integration components. So can you tell us a little bit more about the implementation of these evidence-based care guidelines and how the integration of diabetes systems can facilitate patient-centric care?
Absolutely, Laura. And yes, I mean, I have to say that I'm not totally surprised by the results of the poll because of also what I'm going to say later. But it's one part, and as report identifies that all nations within Europe essentially have tried to address the topic of integrated care by means of policy, high-level guidance documents, etc. So this is already a good sign, but that does not necessarily translate into these policy being implemented or felt at the practice level. So policies are there. So the finding of the report are a reaffirmation that integrated care model is seen as a way forward, and it is a clear evidence that at political level there is a very strong will to make it happen. And it's important. I mean, this is obviously a starting point because these policies and guidances, they galvanize the engagement among stakeholders, including providers, clinicians, people with diabetes, commissioners, so that they can come together and work towards a common, clear, and practically implementable goal. But as I said, I will repeat myself that the scorecard doesn't necessarily measure the implementation aspect, and for policy guidance to be implemented, we need infrastructure, including human resource, including information technology infrastructure. We need financial security, and these are exactly the gaps identified by this paper. The ultimate goal of a holistic patient-centric care can only be achieved if we have full recognition of practical aspects of the integrated care, and through channelized and sustained efforts to address these practical gaps. I can say that this falls largely on national level, but also at international levels, and hopefully the existing mechanisms like the semester mechanism or the projects within the EU framework can somehow facilitate this. So I would like to summarize by saying that these are very good signs, very clear consensus at macro level among stakeholders that this is a way forward. And hopefully this is supplemented by a series of implementable projects across Europe. And in few years' time, if we were to have the same event again, I am hopeful and optimistic that we will be talking about different kind of data. Currently, there are diabetes costs are mammoth. 75%, astonishingly, are due to preventable complications. And then one would question, if these are preventable complications, why aren't they prevented? So hopefully in few years time, when we have this kind of dialogue again, the 75 is likely to be much lower.
Thank you very much, Prabhav. And excuse me, we're going to move towards the end of the sort of discussion about the report. But Ellie, just a final thought from you. What do you want people who read this report to remember and take away as its most important finding?
Well, as we've heard in the last sort of half an hour or so, we've got a lot of really interesting findings in the report. But I think the key thing for me is that I would like people to take a more holistic view of integration. So our results indicate that integrated care is pretty well established as a concept and in policy, although as Prabhav mentioned, policy and practice don't always necessarily follow each other. But very clearly we saw that the technical enablers of integrated systems, so the things that enable technical integrated care to become an integrated system, and we focused on IT and finance systems, these are much less well established in policy. So if they're less well established in policy, then they're obviously not happening in practice. And so if we want to implement truly integrated systems, and that includes all services relating to diabetes care, we need to ensure that we integrate all of these different aspects because they mutually reinforce and enable each other. So we can't have one without the other, or we risk them not working optimally. And I think one final point I'd bring out as well is our final call to action around monitoring and evaluation, because this is one of our calls to action. But interestingly, it's not something we set out to investigate, but it was something that our expert panel and interviewees very clearly stressed to us as important. And it makes sense because without establishing evaluation and monitoring at the outset, how do we know if we've been successful and how do we learn to improve our systems? So really, as my main takeaway, I would like people to take away from the report that implementing integrated systems is a wide-ranging and complex process, and it requires you to consider the technical aspects of integration as well as things such as the human factors of getting individuals to work together.
Thank you, Ellie. And Prabhav, for you, how do you want the different stakeholders to use the scorecard that the EIOU put together to help inform policy making and the implementation of improved diabetes care policies? So what would you like them to do with the scorecard?
So the idea, Laura, is clearly for paper to the report to catalyze the process of implementation. And I'll continue my my speech, but I was trying to imagine that if at the end of this webinar we were to build a word cloud, which are the 3 words that I want prominently to feature within the cloud? And one, by now we all know, is implementation to emerge. The other is patient centricity. I want that to strongly appear at the end. And third would be vertical integration of budget. I think these are the 3. I just thought crossed my mind. So I think in terms of paper use, we absolutely want this paper and the scorecard findings to be discussed, debated, potentially challenged in policy platforms at European level, but more importantly at national level. Methodological point of view, I think paper provides a very good start by asking relevant questions on disease burden, overall integration, but importantly, as we heard many times, on enablers or barriers like financial integration and information technology support. So hopefully a paper finding when discussed at individual country level, and if and when they unpack country level data, this leads to further deep dive discussion in the country. In some cases, it can stimulate or should stimulate further deep dive research on the topic, ultimately to arrive at high level policy guidance reinforcement, but more importantly, adaptation of these guidance documents by relevant stakeholders to build a concrete integration plan. This needs to be backed up by robust data collection monitoring mechanism, as Ellie already mentioned, which should allow us to measure success, allow us to fine-tune the program as it moves forward. And I would like to stress once again that it will not happen in an autopilot way. I think we will need a set of very inspired individuals across the stakeholder spectrum who will have to contribute. And if that happens, then I'm convinced that there will be a paradigm shift in the way diabetes is managed.
Thank you very much, Prabhav and Ellie. And Prabhav is staying with us for our panel that's coming up. And Ellie is going to still be with us for the rest of the webinar. And if you have specific questions for Ellie about the report, then please do message her privately in the chat. She's very happy to reply to you. So please do put your questions to Ellie separately in the chat. But just a quick reminder, if you're going to ask questions to the panel, please put it in the Q&A function rather than the chat, because that's where we'll be selecting them from. So thank you very much, Ellie and Prabhav. And I would now like to invite our panelists for the next section to switch on their cameras if they would. So obviously Prabhav is still with us as well. We are also joined by Chantal Mathieu from the EU Diabetes Forum, Lukianos Gatsoulis, who from the European Commission, so he's from DG Sante. And we're also joined by Christel Scherlmoser, an S&D MEP who has a very specific interest in diabetes and has done a lot of work on this internally within the European Parliament, and will be able to tell you more about that as well. So thank you all very much for joining us. And just as a reminder, you can post your questions now and throughout the panel. So please do put them in, because we'll be taking them periodically through. So Lukianos, I'd like to start with you, if I may. What do you think are the main hurdles to achieving integrated diabetes systems across Europe? And do you think there's anything that the EU can do to help overcome them?
Thank you for the question. Good morning, first of all. Good morning to everybody. Pleased to join you in this event. We're discussing a very pertinent topic when it comes to reforms, transformations of health systems. We do actually acknowledge it is complicated. It is not easy to do. There are many hurdles associated with it. On many fronts, I would say. But if I were to package them into 2 bullet points, I would say one of them concerns the need to mobilize adequate investments to roll out these programs at scale. And we actually need to look for substantial investments up front until we get the payback, the return on investment. We see the benefits coming back from these more efficient programs. The other thing, of course, which is very important, is we need to know how to design and implement these integrated care approaches. And this is not really so evident, so obvious. That's why integrated care is not so widespread either in our continent. We see it mostly in pockets. There are many things to tackle here, such as leadership at political and healthcare level, commitments to do things on the ground, change management, workforce issues to address. Many things have to be done at the same time. And if they are not done right, we face the risk of wasting our investments. So this is really very, very important. What can we do from our side at European level? We actually try to help on several fronts. First of all, by trying to make knowledge available. We have built a repository, an online repository for integrated care. We have collected good practices, detailed case studies, what works well and why and how, tools to help with the design, guidance for assessment, information about all these financing and contracting models. We organize events, workshops to bring together the pioneers with those who want to learn and embark on the journey. We finance twinning projects, as we call them, where some of these pioneers, the early adopters in Europe, work with the next wave of adopters to coach them how to go through the learning curve and implement it correctly. We have technical support schemes who provide hand-on assistance on the ground for people to organize the reforms around integration of care. And we also have a number of financing instruments which can support this in various ways, whether it is the research, the piloting, the large-scale deployment. But I'll leave this perhaps for a later moment in time to talk about it. Thank you.
Thank you very much, Lukianos. And of course, you can post your questions for Lukianos in the Q&A function as well. Chantal, over to you. One of the sort of missions, if you like, of the platform that you are from, or the forum that you're from, is to ensure the translation of research into policy actions towards better diabetes care at a national level. How do you see health data, or how can health data be used to identify where incentives are needed for further vertical and horizontal integration of care?
Yeah, so again, the European Diabetes Forum was created by several societies like EASD, the European Association for the Study of Diabetes, to create a platform where all stakeholders in diabetes come together, not in the least the people living with the disease, to reflect on the key topics, and data is central. Because I've been giving Ellie a very hard time when she wrote this report. I was very critical when she interviewed me, because data is everything. If we want to really design strategies for integration, strategies for incentives, etc., we need to know our enemy. We need to know what we are fighting. And we have to be extremely honest. A lot in the scorecard and in the other tables that Ellie put together is a little bit of hearsay information. I can check my own little country, and I know that some of the things that are there are a little over optimistic. And yeah, we have some integration, but it's far from optimal. And so data is central. Getting the real data. And so as a scientist and a clinician, I'm a big believer that what Europe can do, for instance, could be to create a data gathering. When we say we have 60 million people living with diabetes in Europe, it's hand waving. We have no clue how many have diabetes. And so data gathering is one of the most important things. And that is where Europe can make the difference. That is where structures can be created without a lot of hassle to gather data. But then when you come to incentives, again, I can take examples from my little country, Belgium, where we have projects in, for instance, type 2 diabetes, where we have something called care trajects, where we have a contract between the person with type 2 diabetes, the primary care physician, and the endocrinologist, making a contract to improve the care of this patient. And what are the incentives? Financial, yes, we do get some financial incentive, but honestly, that's the smallest incentive, because you get your 80 euros once a year and then you forget it. But what is the biggest incentive that, together with our government, we've been able to put into that system? It's a reduction of the hassle, a reduction of the burden of the disease for all people involved. For instance, for the doctors, we don't have to write all the paperwork for reimbursement of some medications. Big incentive. For the patient, reduction in, again, paperwork, reduction in specific hurdles that normally he or she would have to take before being able to reach a dietitian. Also, a reduction in hurdles to access to self-monitoring material. So to me, reduction of burden is really very important. And then finally, oh my God, the biggest incentive is satisfaction. Professional satisfaction for the doctors, the dietitians, the nurses in the system, because they see that the work they do leads to something. And that is so important. Do not underestimate the fact that if you have a smooth integrated system in place, everybody is happier. And in the end, that's what we all want.
Thank you very much, Chantal. Christelle, I saw you nodding away there, so I'm assuming there's some points of agreement that you have got with what Chantal was talking about. But I wanted to look at your role specifically, or the role of the different committees in the European Parliament. You're on the ENVI committee, and obviously that has a key role in driving health policies to an extent. How do you see the Environment Committee working with the other relevant committees, such as, economics, budget, some of the other ones, on financial integration in diabetes care? How do you see that sort of process working?
Well, first of all, yes, I do agree with Chantal, and I just wrote satisfied patients should be an incentive in itself. Having happy patients with diabetes feeling better, feeling in control, that should in itself be an incentive for all healthcares. However, back to your question, Laura. Well, in the European Parliament, we are working with health questions in many different ways. But health questions are in itself a national competence, and even with the Health for Europe, the new changes, the health union, it will still be up to the individual member states how to organize and how to finance the healthcare system. But what we do and what we can do in the European Parliament is to have a focus on these issues, put it on the agenda, raise questions to the European Commission, ask for instance, better data. At the moment, we're working with the European strategy for data. And I think that we're talking about a data-driven economy, but we also, in my point of view, talking about a data-driven healthcare system. And therefore, I think that we need more standardized data throughout Europe. And here, I do believe that European Parliament and the ENVI committee can put a pressure on the Commission. I myself have raised this question several times on how to tackle this, because we need to be able to compare. We need to be able to benchmark between member states. And I do, in fact, I am very happy for this report we have seen today, because that is a very good tool to compare between member states. But we need more of this. So we need to put a pressure on the Commission and the member states. But we are not good in we are also internally in the European Parliament thinking in silos. It's not just the member states, it's not just inside the health systems, we are also doing it inside the political system. But I think that there's so many things here we could do and we should do. Knowledge, we also need to spread knowledge. We need to be better in spreading the good and best practices. And we are doing something today, but we could do so much more.
Thank you very much, Christel. We actually have a question that's come in from Thomas Alvin at EFPIA, and I'm going to put this one to Lukianos if you would like to switch on your camera and unmute. And Thomas asks, how could more integrated health financing facilitate not only diabetes care, but also resilient health systems overall post-COVID? So that's a question primarily for Lukianos, but then if anybody else wants to come in on that as well, then feel free to. So yeah, please, Lukianos, when you're ready.
Yes, okay. Happy to make an attempt to respond to this.
You may need to switch your camera on as well.
Okay, I think I switched it on. Can you see me now?
We can't yet, but if it doesn't work, just keep talking.
I will continue talking, and in the meantime, I will be clicking to switch it on again.
Okay, thank you.
I think we have to consider it in the same way as we talk about integrated care. So integrated care, joining up, avoiding duplications, coherence, more coherence, and more efficiency. We need to actually approach this in the way of financing. So moving away from the activity-oriented, volume-based approach to more outcome-based approach requires also a kind of pooling or integration of the financial resources. It is because effectively we are looking at many payers and many service providers working together, and they need to work in a harmonious way. So the integrated financing approaches, in the way that we see in some of these good practices, going for efficient capitated approaches may actually lead to many cost-effective solutions. And if I may actually take it a little bit further, should we manage to succeed in having these more integrated financing and outcome-based approaches, we will ensure the delivery of integrated care services. Otherwise, we undermine them in a way. And again, I go back to what I said earlier, we are at risk of wasting our investments. Thank you.
Thank you. Chantal, do you want to come in on that as well briefly?
Yes, absolutely. And again, first of all, we are putting diabetes forward, but diabetes is actually the poster child of a chronic non-communicable disease. And so everything we're discussing now, you can transpose it to our healthcare systems as a whole. And it is a transition that we're making from acute medicine to chronic disease management. And it needs completely different ways of indeed organizing your healthcare system. It needs integration. When I have a throat infection, I go to my doctor, I'm treated, I'm done. This is for life. And so also our healthcare systems need to adapt. Just a reality check. And when I talk to the ministers, I always say, you will spend your euro anyway. It's up to our healthcare system to decide whether we spend it in prevention or early treatment of people with diabetes or when they're on dialysis. And it's just this reality check that you have to, turn around your investments. But saying that we will save money is also a bit an illusion, because we will have to spend the money, whether it's early on or whether it's later on. But the big difference is the quality of life of our patients, the economic ability to keep functioning. And in the end, for the whole society, it may be better off, it may be cheaper, and for sure for the individual person.
Thank you. Prabhav, I'm going to bring you in here now because what Chantal was talking about re-engineering the way that the approach to financing works. There is an argument that's, that gets made in favor of silo budgeting, that it's actually there to protect budgets and that it gives more visibility and control over spending. However, as we saw with the EIU study, it actually showed that silo budgeting is really inefficient, and that can have a big impact and cost for society as a whole. So from your perspective, can you tell us how and why having a more integrated finance system will concretely help to avoid the inefficiency costs that are linked to actually just keeping budgets in very specific silos? And then Christelle, I'll bring you in on that too.
Absolutely, Laura. And I think Chantal absolutely nailed the principal argument that I would have also brought forward. And one is the monies anyway to be spent, ideally should be spent early in order primarily to achieve better outcomes for the people with diabetes or chronic disease. But that may, and very likely that will, lead to some savings later on. So I just wanted to expand the scope of your question, Laura, a little bit, that silo budgeting, if we break silos, we will lead to financial efficiency. That's true. But a question before that is, if we break silos, will we achieve better outcomes for people with diabetes and chronic diseases? And so both of them have to be seen together. Now, traditional systems, as Chantal also said, have been characterized by management of episodes and separate payment to each provider. So there is no incentive for a provider to work together with another provider. And this is a clear misfit for effective management of chronic diseases such as diabetes. And there are some examples amongst traditional models like fee for service, where if they implement more services, they get more reimbursement, which can lead to overutilization of some services. There are models like capitation, where the whole payment is given and then delivery of services is left to a provider. This can lead to underutilization of services. And in either case, there is no incentive to involve other practitioners, for example. This was for outpatient setting. The same models also exist for hospital, like global budgets or DRG base, or DRG stands for diagnosis group budget, and they suffer from the same shortcomings. So I think it's important for financial services to be aligned to enable integrated care. and this alignment should be vertical, that allows commissioning of services across the patient pathway. I have some examples to quote Laura, but I know Crystal raised her hand several times, so you go ahead, Crystal, first, and then I may come back.
Thank you very much. No, but I mean, I'm no expert here. I just think that when I look into what I have learned working with diabetes for so many years, I have seen several examples, and I'm from Denmark, so please allow me to give it an example here, because I think this can tell us something about what we can do here. Is you might know the Danish Steno Diabetes Center, and that has been now spread out to the whole of the Danish health care system for diabetes. And the idea is that the patient is in focus. So the patient needs to go and see the nurse and the doctor, etc., same day on the same roof. It sounds better when you say it in Danish, but same day on the same roof, so that you focus on what is good for the patient. And building it like that, taking the focus on the patient, have that as a center, and then you build up structures. Then the nurses and doctors, etc., has to be there for the patient on the same roof, and then you have to build up on that also the financial background and incentives. So I mean, it sounds maybe a bit naive putting it like this, but if you start putting the patient in focus, you will automatically be able to build a better system, a better integrated care. You can think differently when it comes to financing, etc. And I know it's difficult, but if you take the patient in focus, then it is easy, because what is for the benefit of the patient will by the end of the day also be for the benefit of the finances. Maybe not for the individual doctor, but for the finances as a whole, for the society. So I think we should learn thinking like that and building it up, circling around the patient. Thank you.
Yes, Chantal, please. And then I also have a couple of questions for you as well, so that have come in from the audience.
And I fully agree again with the person living with the disease being at the center. Now, I always like to think of the slogan of the American Marines, no one left behind. And that's one thing I, as a clinician, always feel very sharply. The weakest, the socially more isolated people should also be taken, because the very active people function very well in these systems. They find their way, they come to the clinics, etc., etc. But we also need to forget that we need to cater for everybody. So in our integrated systems, we should go even as far as also take in the social workers, etc. Because let's not forget, type 2 diabetes, that's very specific part of the discussion, is a disease that hits the socially weaker populations, and they do not thrive very well in systems where the person with the disease needs to find his or her own way. So there needs to be really individualization of care, like Luciano's already said. There needs to be accompaniment for some people, and then, loose systems for others.
Thank you. And we actually have a question for you as well that's just come in, Chantal, which is about, where is it? Interdisciplinarity and transdisciplinarity is only to do with data. Do you also think that Health 4.0 is the solution? I know you understand that question. I don't, but anyway, that's great. Thank you.
No, I mean, it's about sharing, and it's indeed an important discussion point. We just said that the person living with the disease should be a part of the team, and indeed, it's not only doctors; it's also nurses, it's dietitians. What I already said, social workers, psychologists, etc. And in my country, for instance, we had an electronic health record in our hospital, and our dietitians and nurses couldn't access the medical data because they were not doctors. Can you imagine? So breaking these silos open. In our little country, again, we have a national healthcare record system where you can find your way, but again, only doctors can access it. So we need to break down the silos, not only for doctors and people living with the disease, but for all the workers involved in the care of people with diabetes.
Thank you very much. Just we're getting lots of questions coming in from the audience, which is great. Just a quick reminder, please post them in the Q&A, not the chat, because the panelists can't see the chat function so easily. So please, could you focus them there? Okay, so we have another question that's come in from Manolis Mitakis, which is, do you think there should be even more focused differentiation or study separately the strategies between diabetes 1 and 2? And do we have to see these two types as the same disease? Diabetes 2 is very rapidly increasing, and this affects decision-making in spending. I mean, I think this is probably initially a question for Prabhav and Chantal. Maybe if, you know, Lukianos and Christel want to come in or briefly afterwards, then great. But I think maybe Prabhav, you could take this one first and then Chantal.
Absolutely, and I will just make short comment because I know Chantal has very nice views on this one. For me, I think type 1 and type 2 diabetes are different diseases with different needs. Although the principle of the integrated care remains or applies to both the patients, and probably through different mechanisms. I can just say from my view as an outsider to European level policy environment, for example, type 2 diabetes by sheer magnitude constitutes 90% of all diabetes patients and or people with diabetes, and that has changes which you make there will have a larger population level impact in terms of overall population health. But I think the principle of integrated care model should apply to both. Chantal?
Yeah, I mean, it's one of the pitfalls that when you start discussing, you go immediately into details, like thinking, it should be different for type 1, type 2, gestational diabetes. But what I think Europe needs to make the difference is to be able to transcend all of that and really keep the discussions at a very high level. And again, diabetes is important, but even always keep in the back of your mind, how can you make what we propose even generic to other chronic diseases? So go for the big principles, data gathering, registries, and then transposing these data into integrated care. Keep an eye on access to care. And yes, once you come to the implementation, it needs to be adapted to the specific diseases. And in the end, it needs to be adapted to the individual patient. As said, the socially more vulnerable, the more advanced, the young, the old, the frail. So I think, yes, this is extremely important and one of my pet topics, that type 1 is not type 2. But first, we need to agree on the big lines and the principles and the importance of data, integration, digitalization, and what have you.
Thank you very much. Christel, I have a question for you. Obviously, we don't have the actual member state voice represented today, not from want of trying. From your perspective, how do you see the role of the European Parliament in sort of nudging member states in the right direction on this? You know, what can be the role there?
Well, first of all, I think what we can do is to play a role in creating awareness about the problems and showing the best examples of how things are done, and asking the Commission to keep on benchmarking member states. So, I mean, we are a kind of a watchdog, and we can put pressure on the Commission so that the Commission can put pressure on member states. And you know, this name and shame kind of systems, they do have an impact on the member states. Every member state hates to be number last in every benchmarking, so it has an impact, and I think here we can play a role. So asking the questions, creating awareness, keeping up, you know, making a lot of meetings, showing the best example. That is what we are doing, and that is what we need to keep on doing in the future.
Thank you. And Lukianos, I'm going to bring you in now. How do you see the European Commission in terms of its ability to move member states towards adopting policies in favour of more financial integration in diabetes care? Do you think there is something that can be done through the European semester and country-specific recommendations, which kind of builds a little bit on what Christel was talking about?
Yes. Let me say that we are actually doing something already along these lines. And it started from the launch of the communication on the digital transformation of health and care back in 2018. And if you recall that, there was a set of actions around the promotion of person-centered care. So based on this, we worked with member states to try and identify also what is of interest to them, a number of digitally enabled integrated care practices. And through this work, actually, we have launched a large project under the health program, a joint action. It kicked off earlier this month, where around 14 member states participate in an effort to transfer and adapt to local context for good practices on digitally enabled integrated care. So we are doing this already. And the inspiration for that was the communication of 2018. Now, the semester can provide additional inspiration, of course. Bear in mind, though, that the country-specific recommendations are not detailed to very, very specific things. They are actually phrased in a more broad and more general way. But it's up to the member states to identify when we talk about accessibility in a country-specific recommendation, when we talk about resilience, or when we talk about improving care in primary care settings, what could they do? So a bit of imagination applies here. And I would say that in this particular year, there is also a financial incentive for member states to respond to country-specific recommendations. This is very much in the form of the Recovery and Resilience Facility, one of the new programs that have been suggested by the Commission for the next 7 years to help recover from the pandemic of COVID-19. So member states can invest in health reforms and in areas of their health system in order to respond to the COVID crisis and address the challenges identified with the country-specific recommendation. They can use financing from this program to do so. I think this is already a big nudge from the Commission to tell them that there is also financing available to do things. So I don't need to dwell more about this.
Thank you. We've actually got a very interesting question that's come in, I think, for Chantal from Tamara Denny, which is why not support the development of more specialized diabetes hospitals or units that treat diabetes, like there's one that she references called Diabeta in the Netherlands. And she asks, they apply value-based healthcare and have very good results and are very patient-centric. So what's your view on that? Should there be more of these specific hospitals, Chantal?
Yeah, first of all, diabetes, and oh my God, what a name. It means better diabetes. So what a good name. But it is very specialized centers for people with type 1 diabetes mainly. So again, it's at a very granular level that we're discussing here. So if you look at our little country, again, we are one country without data. We don't know how many people have diabetes. We guess that there's about 35, 40,000 with type 1, and we guess about 500,000 with type 2s. The type 1s, yes, integrated clinics, yes, specialized care, but 500,000 type 2s, you just cannot organize it in specialized clinics. And their primary care does such a fantastic job as long as they are supported with dietitians, with education, with nurses to assist them. So again, I wouldn't want to force people in specific directions. I think we need to give, and I loved what Luciano said, it's at the European level, we can give inspiration, we can give nudging and give good examples of how you can organize it, but then how to organize it in your country, it needs to be specific and adapted to your healthcare system. And I think really, if I may add to Luciano's, where Europe can make the difference. I mean, you hold the research budget. So stimulate research projects also to explore what it would take to do good clinical research in that matter. Give a research budget to install in the CDC that exists for Europe also a part that looks at chronic diseases like diabetes, and we're going. So yeah, not too specific, not too granular, and don't force systems onto people.
Yeah, Prabhav, I was going to bring you in, so I'm glad you raised your hand, please.
Yeah, thanks. And I absolutely agree. I think both Luciano and Chantal made great points. I just wanted to reinforce with the help of some examples. I mean, it's hard for at least me to imagine a single model that's going to work across all the heterogeneous culture and heterogeneous healthcare setup that we have in European countries. So there are, as I think Crystal Luciano both mentioned, there are some best practice examples in individual setup. There is one in UK, which touches the point raised in the question also, where you enable or empower primary care to manage diabetes in a certain way and leave complicated type 2 diabetes patients as well as type 1 diabetes patients for the specialists. That setup works well, and that's perhaps the only way, because there is no way everybody with diabetes can be managed with specialist setup. It's just a massive problem. So there are examples in UK. There is a good example in Portugal, as I highlighted before, and it almost invariably comes back to the integration element. You empower primary care, but help them work really well with a specialist in order to achieve right management for person with diabetes.
Thank you. I'm actually going to ask you all on the panel now, just as it's a very brief question, just if you could say yes or no, is do you think there is openness amongst the EU member states to work together on this? I mean, do they have the, obviously there are countries that are at different stages of development and thinking and also sophistication of system, but do you think it would be possible for the countries to work more in a cross-border fashion? I mean, who would like to have a, does anybody want to bite on that question?
Taking inspiration from, since I'm still unmuted, taking inspiration from one country for the other countries is the model that I think will work.
And Christelle, yes.
Well, I'm sure that the majority of the member states would definitely like to cooperate, but it's also difficult I mean, we have several different models for how you organize and finance your your health systems. So therefore, it's also difficult to copy paste completely. But of course, member states wants to cooperate, and many member states would also like EU to finance the health systems, because many member states really need more money. But I'm sure that the majority are really keen on trying to make it better for their citizens.
Thank you. Luciano, I mean, you're welcome to come in on this if you want to. I also actually wanted to talk a little bit about the budget. I mean, obviously, we're not quite sure what's going on there yet, but let's hoping the budget is approved. Do you think there could be scope in it for sort of more support for, national integrated diabetes systems?
Yeah. Before I start addressing this question, can I also say that from my side, I do sense there is also appetite from the member states to cooperate on these things. The evidence is the joint action that I talked about a few minutes ago to transfer the best practices in integrated care. But I have also seen over the past years in an initiative called the European Innovation Partnership on Active and Healthy Aging, many member states and many regions in particular coming together to learn from each other and develop innovative solutions for health and care systems. And they did that because they believed in the value of collaboration. It was an initiative which was not actually supported by any particular funding program or financing. It was voluntary collaboration, and so many authorities actually stepped forward to work on this. So certainly the appetite is there. On the financing front, yes, the negotiations are still ongoing, so we do not know exactly how things will shape, but based on what was proposed in May by the Commission, there are a number of programs in this new MFF package that could support work on integrated care. It could be, for instance, Horizon Europe and Digital Europe, which could take more of a research, development and piloting work in the domain, also with emphasis on digital tools. It could be the EU for Health program, which could actually take the piloting further and promote a stronger collaboration of best practice exchange. It could be the cohesion policy funds, the ERDF and ESF, which can help countries and regions go for larger scale deployment of integrated care solutions. I quote, for example, what is happening in the current programming period. More than 1.5 billion euros from the cohesion policy funds are used to support the work on health system reforms. And some of this goes towards more integrated care approaches. Why you can, of course, expect this to continue in the next MFF. I talked about the Recovery and Resilience Facility already, and there is one more of interest, the InvestEU program, where public authorities, private entities, project promoters can try to attract the interest from the European Investment Bank and other investors to invest into solutions such as novel care models, e-health, facilities for primary care, facilities also for integrated care support, and so on. As you can see, there are various possibilities going all the way from the research domain to the large implementation. So I would like to say that we can cover quite a lot. Thank you.
Thank you. Chantal, would you like to just give a thought on what you've heard so far?
Well, I heard a lot of willingness from our policymakers to indeed pursue our path. I mean, this is not new. We've been working on it for many years now to try and put non-communicable diseases, and again, diabetes is one of the examples we love to use because it is the example for the need for integrated care. So I heard a lot, and I think we need to be realistic and say, what can we do at the European level? That's also what we want to do with the European Diabetes Forum. Bring together all the stakeholders, people living with the disease, everybody involved. Also, this is an EFPIA organized webinar. So having also the companies who make the agents that help us treat people with diabetes should also be in the debate, because they also need to help reflect on how to reorganize and integrate the care and use the agents at the right place so that our healthcare systems can cope with this epidemic that is diabetes. I heard data, and I'm extremely happy that Crystal said, yes, we really want to support this, because knowing what you fight against is essential. I heard digitalization, crucial, reducing the burden in bringing in the data, for instance, and also allowing us to finally analyze outcomes and analyze indicators of the quality of our care. And then finally, I also want to really emphasize what we discussed also, the access to care, and that every person living with diabetes has the right to access, not only those who find their way in these systems, but also those who are a little weaker and a little frailer. They should also be in there. And that's what we want to do with the European Diabetes Forum. We will work on making policy advice on data, on integrated care, and on access to care and digitalization. So yes, I think a very stimulating discussion.
Thank you very much. And we're actually going to move into our closing kind of remarks round now. So I'd like each of the speakers, including Ellie actually. So Ellie, if you'd like to unmute and come back onto camera. I'd like very much for you to all give your one specific recommendation or pick up on something from the EIU report and comment on how you see that recommendation being important for moving forward towards more integrated diabetes care. So I'm going to start with Crystal, please. So your 1 minute thought.
Thank you very much. Well, I think it has been so interesting, and I think that I still learn new things. We still learn new things, but we also need to do more together. And the first recommendation, putting the patients at the center of the integrated diabetes services, is what I find the most important recommendation. So that is what I will take with me and take back to the European Parliament, and hope that I can, together with my colleagues in the Parliament, put higher up on the agenda and create more awareness. Thank you very much.
Thank you very much. Chantal, what about you? So we got patients first. What about, or patient-centered? What's your recommendation that you'd like to see taken forward?
Yeah, I mean, I'm boring. I need to go with people with diabetes at the center. That's crucial. If it doesn't matter to them, if it doesn't impact them, everything we propose is futile. So people at the center, but then keeping a very close eye on the two others, because we need to be clever and find ways to allow our healthcare systems and our budgets to cope with this this complex disease that is diabetes. And the more granular you go to the specific individual diseases that are in the bucket of diabetes, the more difficult it comes. So people at the center, but keep an eye on the budgets, and oh my God, get the data and evaluate.
Thank you. Ellie.
Well, I would agree with what others have said in terms of all three of them are important, and I would say that as an author of the report. But for me, I think the financial structures are very important, because as we've put it in the report, you have to incentivize the integrated working that you want to see. And for me, I think it was surprising that integrated care, in policy at least, is so well established, but the integrated finance were not. And to me, that seems like a big gap in terms of ensuring that policy then translates and becomes practice. So I would say the financial structures, whilst, as Chantal says, making sure that all of those aspects are covered.
Thank you very much. And Lukianos, final thought from you.
I would also talk about the aspects around the financing, the contracting, and the payment. I think the three words go together here, because it's all about making all the stakeholders work together. The clinicians, the service providers, the other informal carers, the NGOs, the voluntary organizations, and the payers. These models need to be designed in a way that all the stakeholders are happily joining their efforts, and they are willing to work in a shared way, sharing the risks, sharing the rewards to make it happen. Otherwise, it can fall apart.
Thank you. Thank you. And Prabhav, your final thought.
Yes, I want to hinge on what Lukianos just mentioned. I'm a little bit more attached to practice than high-level recommendations. I would say vertical integration. I absolutely noted the point that satisfied patient can be a very strong incentive, but at least I do not see that alone influencing the entire healthcare community to behave in a different way. I think they are practicing in a certain way, and if you want the change to happen, there needs to be a concrete incentive, either in the form of finance, in the form of restructuring, ease of doing business, like Chantal mentioned, but I think these things are critical. So that would be my focus, vertical integration of the budget. I just also wanted to note one caveat of the report itself that Chantal had mentioned. It is a cross-sectional report, so it doesn't necessarily reflect if a country has moved from right to left over the last 5 years, for example. So it has to be seen with that angle, and report details can be challenged like Chantal just did. So I'm very happy with this discussion. And my hope is that there are people within the audiences, also those who will visit on-demand session later date, are amongst the countries and play an instrumental role in bringing this discussion to that national setup.
Thank you very much, all of you. Thank you very much to our speakers. It's been a really interesting and interactive discussion. Thank you also to the audience for all your great questions and comments. Just a quick reminder, you have both the report and the scorecard in the link, and the Economist Intelligence Unit actually has a very interactive page around the scorecard. So I would encourage you to go and visit that and have a look and sort of see what is different and what works well across the different member states, and of course the UK as well. And just a quick reminder, you can re-watch this webinar on YouTube or on the EFPIA website at a later point, or share it with colleagues who weren't able to join today. But in the meantime, on behalf of EFPIA and everybody speaking today, thank you all very much and have a good rest of Friday.
Thank you very much. Bye.